Hello, everyone. I'm Jenna Wiens, and thank you so much for inviting me to come and speak with you all today. I'll be talking about my work on augmenting clinical decision-making with AI. So in hospitals today, we're collecting just an immense amount of patient data. And in my research group, we develop and we use this information and machine learning techniques to detect patterns in these data that can be used to sort patients from low risk to high risk for a particular adverse outcome or event, or to match patients to appropriate treatments with the ultimate goal of augmenting clinical practice and improving patient care. And given the challenges that today's healthcare system is facing, there's a critical need for such clinical decision support systems. Currently, the demand for clinical care far exceeds the supply. And economists had anticipated this even before the global pandemic. By the year 2030, economists had anticipated a potential shortfall of over 100,000 physicians. And this shortage exacerbates what's already a serious issue in the field, clinician burnout. At this point, the increasing computerization of the field of healthcare is widely cited as a contributor to the problem rather than a solution. Clinicians are spending more and more time entering and studying data about their patients while still ignoring the vast majority of it. So this burnout, combined with a lack of tools to make sense of the data, has contributed to a large number of medical errors. A study published in the British Medical Journal in 2016 estimated medical errors as the third most common cause of death in the US after heart disease and cancer. And to put this in context, there have been over 600,000 deaths in the US related to COVID-19 since the beginning of the pandemic. These issues highlight an important need, but also an opportunity for AI to alleviate some of these issues. In my group, we gain inspiration from a number of different clinical problems, from diagnosis and risk stratification for adverse outcomes, like healthcare-associated infections, respiratory failure, and Alzheimer's disease, to matching patients to the right treatments through our work in sepsis, diabetes, and metagenomics. And in all of these projects, we collaborate closely with clinicians who help guide us and keep us on track to make sure that we're solving the right clinical problem. So our work is about improving or augmenting healthcare, but we know that models are error prone. And moreover, rarely can they perfectly capture all of the nuances of a complex clinical situation. So we aim to address some of the challenges in building clinical decision support tools through augmentation rather than automation. However, when most people talk about augmentation, they talk about augmenting clinicians, but it really works in both ways. The clinician can also augment the model and make up for some of the model's mistakes. So in today's talk, I'm going to describe 3 projects along these lines. The first focuses on augmentation in the context of making diagnoses, while the second presents some of our more recent work that we've been doing in response to the pandemic. And the final project describes the prospective validation of a real-time risk stratification model for healthcare-associated infections. So first, let's consider the problem of diagnosing patients who present with acute respiratory failure. So there are several underlying causes for developing acute respiratory failure, but the most common ones include heart failure, pneumonia, and COPD, or chronic obstructive pulmonary disorder. Deciding or diagnosing the cause of acute respiratory failure is a challenging clinical problem. In up to 30% of cases, patients may receive incorrect treatments, and this can lead to harm. Tools that could help clinicians in making diagnoses could ultimately improve outcomes. So Using a deep learning model, we applied deep learning to chest x-rays with the goal of learning to diagnose. So what is the probability that this individual has pneumonia? What is the probability that this individual has COPD? And what is the probability this individual has congestive heart failure, or CHF? And here the probabilities do not sum to 1, since patients can have multiple underlying etiologies. So our study population consisted of nearly 1,300 patients admitted to U of M over the course of a year, and included patients who developed acute hypoxic respiratory failure. Each patient admission was reviewed independently by at least 2 physicians and assessed on a scale of 1 to 4 for COPD, CHF, and pneumonia. And these scores were then averaged and thresholded to produce binary labels used for training and evaluation. And well, there's been a lot of work recently on applying deep learning to chest x-rays. Much of it has focused on chest x-rays taken in an outpatient setting. In contrast, our cohort included many critically ill individuals, some of whom cannot get out of bed, resulting in greater heterogeneity. So here I'm showing you on the right an example chest x-ray from the Stanford Chexpert dataset. This is a large publicly available dataset. And on the left, in contrast, I'm showing you an example from our dataset. And while such heterogeneity makes the problem more challenging, it also makes it more realistic. These are the types of patients we are likely to see with acute respiratory failure for whom we'd like to make a diagnosis. So these are the patients that we're going to focus on. So early on in the project, the models we were training to predict the diagnosis were doing really well, too well. So when we looked at what aspects of the chest x-ray the model was using to make its diagnosis, things looked a little weird. It was picking up on things like breast tissue or bone structure, which are not radiological findings that are typically relevant in clinical care. And that's the problem with AI. Well, it's really powerful. It's also susceptible to biases and shortcuts. So if your training data exhibits a strong correlation between, say, being female and having a specific diagnosis, then the model can simply learn to exploit this shortcut. And while this might work well for the training data and might even work well in a subset of the test data, if it's not clinically meaningful, it can fail to generalize when the relationship doesn't hold in the deployment environment. So for example, another patient population or even another institution. And this is well known in other domains as well. So this has been shown in other computer vision tests not related to healthcare, where you have a model that's trained to recognize cows on a biased data set, and it fails when the cow shows up in an unexpected place, because instead of learning what makes a cow, the model has simply learned to recognize the background of a cow. It's learned the shortcut. And this presents a serious issue in healthcare, since models can perpetuate or even exacerbate human biases in clinical care. So in the context of learning to diagnose based on chest x-rays, we sought to identify potential shortcuts and characterize the ease with which models could exploit those shortcuts when making diagnostic predictions. And this was work that we presented at last year's Machine Learning for Healthcare conference. So you can find the full paper at JMLR, but I'm going to tell you a few of our main results. So first, we looked at how easy it was to learn whether or not a patient was female based on a chest x-ray. If this was a very challenging task, so if the model couldn't tell female from not, then it's not really a shortcut. But the model did so with near perfect accuracy. So here I'm showing you the area under the receiver operating characteristic curve for the binary task of whether or not the patient in the chest x-ray was female. And We did this in our data set, remember 1,300 patients, a rather small data set. And these are results on the held out validation or held out test set. We also repeated this with the MIMIC data set, which is a publicly available data set of chest x-rays, and the Stanford Chexpert data set. And we showed that in all three cases, it was a very easy task for the model. So beyond male versus female, we found that deep learning models can learn to map chest x-rays to a number of potentially sensitive attributes. So here I'm showing you the data for age, but it could also learn body mass index and even race. So when these attributes are correlated with the outcome of interest, a model can use them as a shortcut in its prediction. And this creates a problem when transferring across institutions where demographics might shift. For example, a recent paper published in Nature Machine Intelligence showed that several attempts at diagnosing COVID-19 from chest x-rays were flawed. And in particular, one study trained the algorithm on infection-free images taken from scans of children and compared them to positive scans from adults. Not too surprisingly, the model took the shortcut of predicting adult versus child rather than actually detecting COVID. So the potential of shortcuts related to sensitive attributes can also lead to bias amplification, in which human biases are not just replicated, but actually amplified by a model. And this has had consequences in other domains as well. So in 2018, Amazon had to stop using a tool to filter applicant resumes when it was revealed that the tool was leveraging shortcuts related to gender. So while shortcuts based on age and sex and race are particularly worrisome, there are other sources of shortcuts that can be detrimental when it comes to model performance. So consider these two individuals, well, these two images of the same individual, except for one small difference. And I challenge you to try to identify what the difference is. So these images will look different on everyone's screen. Some people have said, oh, one looks brighter than the other, or one looks larger than the other. The images are identical except for how they were pre-processed. So we used a Gaussian filter to pre-process both images, but the one on the left, the filter had a standard deviation of 0.4, and the one on the right, the filter had a standard deviation of 0.5. Now, I have yet to come across an individual who has been able to tell the difference between these two images or be able to correctly identify that the difference was in fact the filter standard deviation, but a model can tell this difference with perfect accuracy. And this is really worrisome because if the pre-processing is applied differently across institutions, and some institutions tend to see sicker patients, then this can easily introduce a spurious correlation between pre-processing and outcome. And this is particularly concerning since oftentimes pre-processing might not even be reported or recorded. So we don't know how the data were actually pre-processed before we start learning a model on them. So recognizing the potential of deep learning approaches to exploit shortcuts, we investigated approaches that could mitigate such behavior, prevent it from taking the shortcut. And there's been a lot of previous work in this area, but prior to our work, a lot of the work had focused on resampling the data or reweighting the data or adversarial training. However, when the bias is really strong, if you have a near perfect correlation and the training set is small, these approaches fail. And this is often the case in healthcare where you can have strong spurious correlations and very limited training data. So instead, we investigated a simple transfer learning approach to see how well it could do at mitigating such behavior. So in short, we want to encourage the model to rely on clinically relevant features that are more likely to generalize across populations. You can think of these features as the type of radiological findings that a clinician would rely on. A clinician can make accurate diagnoses at one hospital or another. A clinician does not rely on shortcuts. So we want a model to take a similar approach and rely on common radiological features when diagnosing disease. So in our setup, we aim to solve a target task. So in our case here, the target task is diagnose whether or not this patient has CHF. But we're assuming we have only a small, potentially very biased training set to learn from. So if we were to just leverage this training set, we'd almost certainly learn the shortcut, the spurious correlation, and fail to generalize. So in addition, we assume that we have access to some related but curated source task data set. So here the source task is whether or not the patient has pneumonia, and it's related in the sense that it shares similar features. Similar radiological findings are used to diagnose these two outcomes. So our approach is two-staged. In the first stage, we learn a model. In this case, it's a dense net composed of an encoder and a linear layer F on the source task. And this results in model parameters theta for the encoder and W for the linear layer. And then in the second stage, we freeze the encoder parameters and essentially extract features from the input image, and we retrain the last layer on the target task. So this is our small, potentially very biased data. And though simple, such an approach proves surprisingly effective. So assuming a target task of congestive heart failure in which there's a strong correlation with age greater than 65, simply training on the target task does significantly worse compared to using transfer learning. And we showed that this held across other shortcuts or sensitive attribute shortcuts like sex, BMI, and race. And we also showed that it held even for treatment-based shortcuts like whether or not the patient has a pacemaker. And transfer learning is a well-explored area. So this isn't a new approach, but it's a surprising result that the last layer simultaneously has the capacity to learn an expressive model, while also not enough capacity to overfit to this very strong bias in the target task. So the full set of results, again, are available in our MLHC paper, but I would just like to highlight the student who worked on the project. This is Sarah Jabbour, who's a PhD candidate at Michigan, along with my clinical collaborators, Dr. Michael Shoding and Dr. Kazaruni, who are at Michigan Medicine, pulmonary critical care physician and radiologist. And finally, my colleague, David Foey, who is a faculty member in computer science and engineering with expertise in computer vision. And if you want to start training models in this way, check out our code that's available on GitLab. But we didn't stop there, right? So based on this work, we conducted a pilot study in which we showed clinicians a clinical vignette, like the one that I'm showing you right here, that clinicians, med school students are used to seeing. And we asked them to diagnose the patient. Does this patient have CHF? Does this patient have pneumonia? Does this patient have heart failure? And in the pilot study, we found clinicians had an accuracy of around 70%, which is kind of what we expected. We knew that in roughly a third of cases, patients receive incorrect initial diagnoses and treatments. But when we presented the clinicians with an AI tool, it helped a lot. So this tells us that physicians are willing to embrace the AI and trust the AI, but perhaps a bit too much, because when we replace the AI with a very biased AI tool, the performance of the clinicians completely tanked. So they began to over-rely on the tool. And similar results were reported earlier this year by Goeb et al. And while Goeb et al. Showed that clinicians could, to a certain extent, identify inaccurate advice and rate it lower quality, this study that we're doing right now is going to look at to what extent we can equip clinicians with the tools that will allow them to recover from the bad advice. So not just recognize it, but also recover from it so that their accuracy with an AI tool is at least as good as the accuracy without the AI tool, and better when the AI tool is accurate. So based on these findings, we've formed an interdisciplinary team consisting of experts in computer vision and human-computer interaction, along with clinicians from Michigan Medicine. And our planned study includes an analysis of to what extent clinicians can recover from bad models when equipped with the right tools. So the work that we presented at Machine Learning for Healthcare with using transfer learning to mitigate bias was a computational based approach. And now we're looking to measure the extent that humans themselves can recover from these biases as well. So takeaways. One, deep learning models can classify demographics, treatment, like whether or not a patient has a pacemaker, very easily. So when training data are skewed, shortcuts can be exploited, and this can lead to poor generalization performance and worse bias amplification. Two, transfer learning is surprisingly effective at mitigating such shortcuts. And beyond computational approaches to mitigate such shortcuts, we're now looking at human-based strategies, measuring to what extent humans can pick up on bias models that are erroneously relying on shortcuts. And I think it's this kind of collaboration that will be most effective in improving the generalizability of models across populations and institutions going forward. So moving on to the second part of our talk. So in early March, the first few COVID-19 cases in the state of Michigan were recognized. And by late March, and this is March 2020, our capacity to test improved and the total number of cases quickly rose. And though Michigan Medicine started with just a handful of cases without intervention, it expected the number of admitted patients with COVID-19 to increase exponentially in the coming days. And this exponential increase combined with a potential shortage of resources led to tough questions. So here at Michigan Medicine, hospital leadership began to explore converting an indoor track into a field hospital to meet the demand. And around this time, members of the AI lab partnered with members of Michigan Medicine to develop clinician decision support tools. Specifically, tools that could help identify patients at greatest risk of complications or adverse outcomes from the disease. So for example, those who might need respiratory support, including mechanical ventilation, cardiovascular support, like IV vasopressors, and those who would likely die in the hospital from the disease. And such a predictive model could help the hospital manage a surge in COVID-19 patients and anticipate needs well in advance. So given that, along with the rest of the world, we knew little about this disease and potential risk factors, we took a data-centric approach to the problem, leveraging the contents of the electronic health record to learn accurate models for predicting adverse outcomes. And within the EHR, we have everything from what medications patients are taking to frequently measured vital signs like heart rate. And using these data, we learned a mapping from the EHR to an estimate of patients' risk of experiencing an adverse outcome. And the score was developed in such a way that it was assessed repeatedly over time as new information became available. So from a machine learning perspective, we encountered numerous challenges. So including the fact that these cases were increasing rapidly, there was relatively little training data from which to learn. So to tackle this issue, we leveraged data from a large retrospective cohort of individuals presenting in the emergency department with respiratory symptoms. We held out individuals with COVID-19 for evaluation purposes. But again, due to the limited number of cases and the accelerated deployment timeline, we had to find alternate ways to scrutinize the model to limit issues during real-time deployment. And finally, though we started with thousands of variables in an effort to produce a model that could serve not only Michigan Medicine, but other hospitals across the world, we aimed to simplify the model or reduce the model to a subset of readily available data in the EHR that could easily transfer across institutions and populations. So we evaluated the model's predictions on a held out test cohort of 200 patients. And in particular, advised by clinicians in the hospital, we focused on two use cases. The first is the most common use case, and that's to identify individuals who will experience the adverse outcome. So who's at high risk early after admission. And nearly 30% of the test cohort met this outcome. And the MCARES model, the model we developed, achieved an area under the receiver operating characteristic curve of 0.8, so good discriminative performance, while correctly identifying half the patients. So a sensitivity of nearly 50% resulted in a positive predictive value of 65%. This significantly outperformed a proprietary deterioration index that the hospital had considered using during the early days of the pandemic, provided by Epic, an EHR vendor, where for the same positive predictive value, the sensitivity was significantly worse. So based on the feedback from clinicians, in addition to identifying the high-risk cases, we also looked at identifying the low-risk individuals. So among those who do not suffer an outcome in the first 48 hours after admission, who is unlikely to suffer an adverse outcome in the remainder of the admission. So these are potential candidates for early discharge. And in our COVID-19 test cohort, roughly 78% of the population were low risk. So MCARES was able to accurately flag nearly 20% of the population as low risk with 0 false positives, meaning that of the 20% or 19.3% that were flagged as low risk, none of them went on to experience the outcome. Whereas the EPIC score, if we want the same stringent 0 false positives, was only flagged 1.4% as low risk. So at the same time that we were working on this clinical decision support tool, the governor in the state of Michigan implemented a stay-at-home order. And fortunately, the curve flattened. And Michigan Medicine did not have to open the field hospital, and clinicians did not have to turn to using MCARES. But we didn't stop working on the model. So in addition to the internal validation that we had done early on, we continued to validate the model on patients with COVID-19 at Michigan Medicine, and we partnered with several other external institutions to validate the model on over 9,000 hospitalizations over the course of the first year of the pandemic. And preliminary results look really encouraging. We were able to get similar, if not better, results. So here in blue is the discriminative performance at Michigan Medicine on the full year of internal validation. And then we have the other hospitals here, A through G, that similarly have good discriminative performance. In addition to this external validation, we're also running the model in the background at Michigan. So it's integrated into the EHR, it's running in real time, and it's making predictions every 4 hours for everyone in the hospital. And this will allow us to prospectively validate the model. Which brings me to the last part of my talk, in which I'll describe a project that we've been working on for perhaps the longest, that's also the closest to impacting clinical care. We have been focused on predicting healthcare-associated infections. So healthcare-associated infections are one of the top 10 contributors of death in the US. And in particular, we're interested in infections with Clostridioides difficile. The most common type of healthcare-associated infection is a type of bacteria that takes over the gut when normal flora get wiped out, and it can lead to colitis and even death, and is associated with excess medical costs in the US of billions of dollars per year. Most recent estimates were over $4 billion per year. And we hypothesize that one of the reasons that these types of infections remain so stubbornly prevalent is because we lack effective tools for measuring patient risk. So given that the risk factors are multifactorial, just like MCures, we take a data-centric approach to the problem, where we aim to learn a mapping from the electronic health record, which again contains information on medications, procedures, even where the patient is in the hospital and who's in the bed next to them, to a mapping of risk. So which patients in the hospital today are at greatest risk of acquiring an infection with Clostridioides difficile during the remainder of the stay. So our model essentially learns a mapping from the contents of the EHR every day. So as the EHR contents evolve and change, as the patients moved around the hospital, as they're given new medications, the estimated risk is updated over time and changes. So then applied to a new patient, once a patient crosses some predefined threshold, we determine them high risk. We could intervene. And if someone stays below the threshold the whole time, we determine the patient low risk and we don't intervene. And I skipped over all of the model details, but you can find them published in the Journal for Machine Learning Research, JMLR 2016 paper, and further clinical details in Infection Control and Hospital Epidemiology paper. So we developed the model on patient admission spanning from 2013 to 2018, and we validated the model on over 25,000 encounters at Michigan Medicine in 2019. And the model achieved an AUROC of close to 0.8 and a positive predictive value 6 times the baseline incidence of disease. So the positive predictive value looks low, but it's in part due to the fact that the prevalence of the disease is so low, less than 1%. So in addition to the discriminative performance of the model, we also showed that the model can accurately identify at-risk patients well in advance of clinical suspicion. So actually like 5 days in advance on average. So once integrated into clinical care, such clinical decision support systems could be used to guide interventions like targeted environmental cleaning or even whom to test. And this in turn could lead to decreased length of stay, decreased transmission, reduced costs, and ultimately improved patient outcomes. So really excited about the potential for impact. We set out to integrate our model into the EHR such that it could be used to make near real-time predictions that could be passed on to clinical care teams who could then apply interventions. But this required a shift in infrastructure. So previously, all of our retrospective analyses, so all of the model building and validation, had relied on data from a curated research data warehouse. So these data are pulled from Clarity, which pulls from Chronicles, and the data are not updated in real time. They're separated from the database with which providers interact, because you don't really want complex data-intensive reporting that happens in Clarity to impact the provider-facing environment. And moreover, you don't want all of the curation that happens to the research data to impact again, the provider-facing environment. So, well, this is our specific setup at Michigan Medicine. Many academic institutions throughout the world have similar data research or research data warehouses that serve research purposes. So when it came time to prospectively validate the model, so this existing pipeline was fine for retrospective validation. We're able to generate the model and then validate the model on data from 2019. But as soon as we wanted to make predictions in real time, we needed real-time data. So this is where we had to work with developers and programmers to write custom web services that would pull the data every day so that we would have fresh data and allow us to apply the model to these daily extracts in real time. We were getting risk scores for everyone in the hospital every day. And then as the patient clinical course evolved, we would prospectively validate the model. Who did we get right? Who did we get wrong? And I just want to highlight the 3 students who have been working on this project now for several years and have contributed to all aspects. So applied to the task of predicting which patients are most likely to acquire an infection with Clostridioides difficile during their current hospital admission, our patient risk stratification model performed similarly in 2020 to how it did in 2019, with the exception of a couple of months of onset, a couple of months during the onset of the pandemic. So here in blue, I'm showing you the retrospective validation. So how it did from July 2019 up until June 2020. In red, I'm showing you the prospective validation. So how well it's doing prospectively from July 2020 up until June 2021. So just a few months ago. And overall, retrospectively, the model had a good discriminative performance, so an AURC of 0.778. And prospectively, this decreased slightly, but overlapped significantly. So the AURC went from 0.778 to 0.767. Now, you may be thinking, hey, that's not bad. There was a global pandemic, which led to giant shifts in clinical care processes. It's not unreasonable to expect a small decrease in overall performance. But care processes and patient populations were not the only change. Recall that we also had to rely on infrastructure that differed from the infrastructure used for model development and retrospective validation. So retrospective validation, we pulled from this curated research data warehouse where the data, dated back to 2013. So they were, to a certain extent, stale. They had stabilized. Whereas for prospective validation, we were pulling data in real time, and data were dynamic and data were changing. So both temporal and infrastructure shift can affect prospective performance. So temporal shift are changes to patient populations and care processes. So for example, a global pandemic will result in temporal shift. And then infrastructure shift is, where do you source your data from? Is it from the curated research data warehouse, or is it from those web services? So validating on data extracted retrospectively from a research data warehouse from the most recent year seeks to mimic that temporal shift, right? How is my model going to perform over time? But it doesn't account for infrastructure shift. In practice, we'd expect there to be some infrastructure shift. We'd expect there to be some difference, but to what extent? So to answer this question, after the year of prospective validation had completed, we went back and we re-extracted the 2020 data using the retrospective pipeline. So we went back to the curated research data warehouse and we extracted data from 2020. And this allowed us to control for infrastructure. So this is the same infrastructure. How well does the performance, how much does the performance change? And any change in performance here is going to be due to those changes in care processes, those changes in patient population, changes due to time or temporal shift. In addition, we can compare the data in 2020 through each pipeline. So the retrospective 2020 to the prospective 2020, and this can help us identify which differences are due to the infrastructure or infrastructure shift. So when we did this, overall, the performance gap, again, was small, 0.011. So not a big change. But what was really interesting was when we split this performance gap into what was due to temporal shift and what was due to infrastructure shift, we were expecting that given that there had been this large shift in care processes due to the pandemic, that there would be a large temporal shift. That wasn't the case. The temporal shift was actually negative, meaning the task got easier later. The task got easier in 2020 relative to 2019. So the vast majority of the performance gap was driven by infrastructure shift. So the differences between those web services versus the curated stabilized research data warehouse. So in summary, we identified infrastructure shift as a primary contributor to the performance gap. And the heart of the issue lies in the fact that the electronic health record is inherently dynamic. So for example, the start and end dates for medications can change over time as desired treatment plans change. So in real time, it looks like a medication order has been placed, but then retrospectively later, the order has been canceled. And while overwriting records and values may be of little consequence for care operations, it makes retrospective training really difficult and fraught with workflow issues. And EHR vendors are currently developing tools for efficient and effective deployment of ML models, so integrating models into electronic health records and serving up predictions in real time. But we have to be careful, because if we continue to train the models on data from curated research databases that are several steps removed from clinical operations, then issues like infrastructure shift are going to remain. But with prospective validation and analysis, we can start to bridge this gap in performance. And this can start to provide a more accurate evaluation of how the model will actually perform in practice. So to recap, we covered a lot. So from how models are susceptible to bias to how important infrastructure is during model development. I want to stress that AI is far from perfect. We need solutions that seek to augment rather than automate many difficult clinical tasks. But if there's only one thing that you take away from today's talk, know this: it's important, it's critical to develop machine learning for health in collaboration with the people who will ultimately use it and make it better. And with that, I would like to acknowledge all of my students and collaborators. All of this work was a huge interdisciplinary effort, required input from precision health teams, the data office, MyChart developers, and many external collaborators as well. We also are very grateful to our funding sources. If you want to learn more about any of the projects I talked about in this talk or any of our other work, you can hold your camera up to this QR code and it will bring you to my group's website, MLD3, or Machine Learning for Data-Driven Decisions at the University of Michigan. Now, I'm happy to stop here and take questions. Thank you.